A 35-year-old woman has newly diagnosed pancreatitis. Physical examination shows fibrocystic changes of the breast, and serum studies shows calcium 12, phosphorus 1, cholesterol 250, and Tg 120. Urine analysis show hematuria, urinary pH is 4.5. An X-ray of the abdomen shows 4 millimeter calcification in the right upper quadrant, 4 millimeter calcification in the right upper quadrant. An X-ray of the chest is normal. Which of the following is the most likely cause of our condition? Hypercalcemia can cause pancreatitis, isn't it? Hyper, but there is no such options.
Have been newly diagnosed. Adenoma. Um,
TG is not that high. I don't.
Classification in the right record. Notable metastatic breast cancer. Okay, ready?
Is it due to cancer?
No, I think it's due to PTH.
Hypoparathyroid adenoma.
I think so. Or you don't think so? You think it's can it's the but she has fibrocystic changes on the breast. You
Changes,
don't
yes, that is the
but
problem. Why 4 millimeter calcification in the upper abdomen, right upper
right
quadrant?
then I
What
don't
does it indicate?
I don't know.
Okay, let's see what. This is very clumsy question.
Okay, so it's parathyroid adenoma. Parathyroidoma, most common cause of primary hyperthyroidism. Primary commonly presents hypercalcemia, hypophosphatemia, osseous pain, constipation, potential urinary tract calculi, as well. Increasing in calcium concentration is a risk factor for acute pancreatitis. Excessive production of PTH results in increased calcium and with concomitant increased excretion of phosphorus by the kidney. Primary hyperthyroidism most commonly caused by PTH adenoma, followed by parathyroid hyperplasia and parathyroid cancer. Diagnosis typically requires evaluation with technetium, whatever, 99 scan, and treatment involves resection of the parathyroid adenoma. So the right upper quadrant thing was just a distractor.
Okay. So why is the reason?
Is parathyroid adenoma causes a lot of PTH that leads to a lot of uh, calcium, and calcium causes pancreatitis.
So hypercalcemia indirectly. Okay.
Mhm.
A 52-year-old man with type 1 diabetes mellitus. 52-year-old man with type 1 diabetes mellitus comes to the physician for a follow-up examination 3 years ago. 3 years ago, he underwent a cadaveric left renal transplant for diabetic nephropathy. He has been compliant with her treatment, and his immunosuppressive regimen include prednisolone and cyclosporine. He takes lisinopril for hypertension, heart His temperature is 37 degrees Celsius, pulse 80 per minute, respiration 12 per minute, blood pressure 128 by 82. Examination shows moderate fetal edema bilaterally and a tender 10 centimeter mass in the left iliac fossa. His serum creatinine concentration has increased to from 1.9 over the past year to 2.7. Which of the following is the most likely cause of renal insufficiency?
Where is the iliac fossa?
Tumors of liver.
Hmm.
Is there any possibility of chronic rejection?
That's what I'm thinking, but I'm between that and ureteral
Obstruction.
obstruction.
Yes, I am.
Where is the left iliac fossa? Is like at the back or at the front?
Iliac fossa.
It's like where the kidneys are at the back, or is it like at the front in like the
Kidneys are at the back, isn't it? Like kidney surgery is done from the back.
yeah. So the iliac fossa, is it at the back or is it in the front?
Iliac fossa isn't in the front, isn't it? Because according to 9 quadrant of the abdomen, one is right iliac fossa.
Okay, so it's at the front. I don't know. I guess I'll go with ureteral obstruction.
Okay.
Hey, what's ureteral obstruction? Ureteral. I'll do ureteral obstruction. Probably it's kidney rejection at this one. Okay, let's check. Oh, it's chronic rejection. Chronic rejection of a transplanted organ occurs over months to years following transplantation. Is secondary to CD4 T lymphocyte response against donor uh, peptides such as MH, the major compatibility complexes. Resultant T lymphocyte activation leads to cytokine production in both humoral and cellular hypersensitivity reactions, type 2 and type 4, respectively. These reactions result in vascular atherosclerosis and smooth muscle proliferation, with subsequent parenchymal fibrosis and atrophy of the transplanted organ. Okay. Clinically, this manifest as chronic progressive transplant dysfunction. In the kidney, this is referred to as chronic graft nephropathy. Examples of chronic transplant rejection also include vanishing bile duct syndrome of the liver, bronchiolitis obliterans of the lung, and significant rapid atherosclerosis of the heart. Immunosuppressive medical therapy does not adequately prevent chronic rejection. It's associated with increased mortality secondary to organ failure. It may require the reinitiation of renal replacement therapy and or other organ transplant. It is not ureteral obstruction may result in post-renal azotemia from blocked urinary flow from the transplanted kidney. Post-renal azotemia in the setting of renal transplant occurs when the outflow from the transplanted kidney is obstructed from pathology, such as kidney stone, bladder cancer, or ureteral fibrosis or stricture. Hmm,
Okay.
okay, I don't see the clue here, but okay.
Then you copy the question and see it in the.
Let's see.
Yes, we may. You can add also the options also.
Oh,
Then it will summarize everything.
oh, it says my image is incomplete. Why? Oh,
What?
man.
What? You should copy the question and answer.
An answer. Um, it's not copying the whole thing. Oh, this is so. Okay, copy, paste. You just. Oh, now.
It will come, no problem.
52 men, type 1 diabetes, diabetic nephropathy is a common complication of long-standing diabetes, leading to end-stage renal disease. He had a transplant 2 years ago, which means his native kidney likely has severe damage, blah, blah, blah. This is compliant with treatment. This is important because non-compliance can lead to rejection. Immunosuppressive regimen, cyclosporin is blah, blah, blah. Cyclosporin are not to have significant nephrotoxic side effects. Um, Takes lisinopril ACE inhibitor often used in transplant to make hypertension, proteinuria, to manage hypertension. Okay. Vital signs are normal. Moderate pedal edema suggests fluid retention, which is a sign of kidney failure. Tender mass in the left iliac fossa. Left iliac fossa is the common site for transplant. The common site for a transplanted kidney. So I guess at the back. Tender mass here could indicate several issues, including a perinephric fluid collection, hematoma, blah, 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 or simply the enlarged and possibly inflamed graft itself. So I guess it's at the back. Serum creatinine concentration is increased. This gradual progressive increase in kidney indicates chronic renal insufficient graft dysfunction. Okay. Let's evaluate option in the context, blah, blah, blah. Chronic psych, no, we don't care about that one. Chronic rejection. Chronic rejection involves a slowly progressive decline in graft function, blah, 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 leading to fibrosis and vascular changes. Gradual rise in creatinine. However, the presence of a tender mass is less typical for chronic rejection itself, although rejection can lead to kidney swelling. Differentiating chronic rejection for CNI toxicity often requires a biopsy. Possible fit with patient. Possible as it also causes a gradual creatinine rise. However, the tender mass and the specific drug regimen may cyclosporine toxicity direct explanation of the combination. That does not make sense. Conclusion. Ah, Here it says that this is the answer is the cyclosporine toxicity. Never mind.
Hello? Yes.
Yes.
They actually quoted wrong. Like look at
Mm.
the DeepSeek answer. That's why I try to compare with other chatbot.
What do you?
Look here. This is DeepSeek from the Chinese one.
Uh huh.
Another AI. Okay,
Mm-hmm.
I posted this thing.
Mm-hmm.
Look, why it is chronic rejection. So their answer is chronic rejection, final answer.
Mm-hmm.
So it matches. So why
Mm-hmm.
it is chronic rejection? Chronic rejection is a common cause of late onset graft reaction more than 1 year post transplant. It is mediated by both antibody and cell mediated mechanism, leading to vascular and interstitial fibrosis. The tenderness and the enlargement of the graft suggest an inflammatory process. Rejection cyclosporine toxicity is possible, but it typically does not cause kidney tenderness or significant analysis.
Okay. Why is it not ureteral obstruction?
Okay, why it is not ureteral obstruction? They
This.
okay. Uh, they
Why?
actually put the question into history and physical examination. Okay, so 10 centimeter. Look at the physical examination. 10 centimeter mass in the left iliac fossa, likely the transplanted kidney. So this mass is like the transplanted kidney. So one thing we do during kidney transplant, we put the affected kidney into that area. We do not extract the lost kidney. You got my point.
Mhm.
Okay. Ureteral obstruction could be hydronephrosis and rising creatinine, but tender mass suggests graft inflammation, rejection rather than obstruction. Now
Okay.
you satisfied?
Yeah.
Uh, I am sending everything.
Thank you.
So if you are not satisfied with any answer, use another chatbot like
Mhm.
DeepSeek. I like DeepSeek because their explanation is wonderful. Okay. Okay, can you give me 5 minutes? Actually, 5 minutes. I'm coming.
Mhm.
Okay. Okay.
Go ahead.
Next. An 82-year-old man comes to the physician because of growth of on his face 6 months ago. It bleeds easily when touched. It bleeds easily when touched. He worked as a mail carrier for 42 years. There is a nodule with prominent telangiectasia on forehead. Which of the following is most likely diagnosis?
Ready?
Yes.
Okay. Basal cell carcinoma, most common skin neoplasm, typically presents as pink, waxy skin lesion with adaptation, central ulceration, or raw borders occurring sun-exposed area of the body. BCC can also appear as a non-healing ulcer. It can be locally invasive but not doesn't metastasize. Treatment: excisional biopsy with negative margin. If locally invasive or involving sensitive facial structure like eyelid, will require more surgery for appropriate resection. Okay, next.
Next. A 72-year-old man with esophageal a 72-year-old man with esophageal adenocarcinoma comes to the physician for evaluation 2 weeks prior to a scheduled subtotal esophagectomy. He has 20-year history of gastroesophageal reflux disease, treated most recently with PPI, and a 10-year history of hypertension, well controlled with beta blocking agent and ACE inhibitor. He does not smoke or drink alcohol. He is 5 feet 10 inch tall, weight is 127 kg, BMI is 40 kg per meter square. His blood pressure is 145 by 84 millimeter of mercury. Examination shows varicose vein on the lower extremity with no tenderness. There is 1 plus pitting edema. In addition to early ambulation, which of the following is the most appropriate preventive measure for this patient perioperatively? In early varicose. Mm, Ready?
No, one moment. Mm, 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 mm. Perioperatively. Perioperatively means before the surgery. Oh wait, during the surgery. Mm, 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 Danakava. Proton pump. Ah, okay,
Okay.
ready. Low molecular weight heparin. It is the most low molecular weight therapy is the most appropriate operative measure to prevent DVT. DVT, the presence of blood clot within deep vein of the upper or lower extremity. The complication is a common complication during patient admission and in the perioperative setting. I guess it's after the surgery. Formation of DVT is promoted by the presence of features of Virchow triad, like venous stasis, immobility, venous occlusion, endothelial injury, and infection, trauma, inflammation, and hypercoagulability, like perioperative state, malignancy, genetic, whatever. A patient with history of malignancy, surgery, and mobility is at substantial increase for the development of DVT. Modifiable risk factor actions to reduce the incidence of DVT during admission include minimizing mobility with early post-surgical ambulation, a use of prophylactic anticoagulants such as subcutaneous heparin when seemed appropriate. Is not inferior vena cava filter is indicated for the prevention of pulmonary embolism from DVT in the lower extremity when a patient has contraindication to therapeutic anticoagulant. It will not prevent DVT in the perioperative. It's not aspirin are antiplatelet common use in prophylaxis of arterial thrombotic phenomena involving the coronary arteries like MI, cerebral arteries, along with primary antiplatelet therapy following intravascular stent placement. They do not have a role in DVT. Okay, next.
So during surgery, perioperatively, we can use low molecular weight heparin to prevent DVT.
I guess during surgery, right? Perioperative.
Yes,
Okay.
perioperative is during surgery, isn't it?
No, it means beef. Uh-uh.
Preoperative
Perioperative.
is before. Peri is with during, isn't it?
Let me confirm that. I don't know why it doesn't. Okay, wait. It refers to period of time surrounding a surgical operation, encompassing the time before, during, and after. So around the time of surgery. Okay. So it involves all of them, I guess. Yeah.
Okay,
It involves all of them. Yeah.
okay. Let's move on next question. 1 hour after delivery at term, 1 hour after delivery at term, a 3.7 kg female newborn began to choke, cough, regurgitate when attempting to breastfeed. Pregnancy and delivery were uncomplicated. Pregnancy and delivery were uncomplicated. Apgar score were 9 and 10 in 1 and 5 minutes respectively. Examination shows no abnormality except for drooling. Which of the following is the most appropriate next step in the diagnosis?
Hmm. No, no, the little CT scan. Oh, no. I don't think we don't do CT scan on babies, huh? We do ultrasound.
Yes,
So is it barium? Sort of barium? Probably, no, it's insertion of it. That's the
it is. I think that it is TEF, or like
what?
esophageal atresia with tracheoesophageal fistula. Like when a newborn baby, you try to feed a newborn baby and he start to regurgitate, just then it may be T tracheoesophageal fistula. So I think that insertion of the NG tube.
It can also be the cloanal atresia, the nose one.
Yes, it can
Yeah.
happen.
But yeah, I think it's insertion of the thing. Let's see. Yeah, insertion of the nasogastric tube. Insertion of the nasogastric tube is the most appropriate next step in diagnosis. In the evaluation of potential esophageal atresia with or without tracheoesophageal fistula. The typical presentation for a newborn with esophageal atresia is inability to feed with associated gagging and inability to manage oral secretion. The presence of TEF conveys an increased risk for aspiration pneumonia, respiratory distress. Initial evaluation requires placement of the nasogastric tube and evaluation of its position within the chest X-ray, with the chest X-ray, sorry. If the nasogastric tube remains cold within the esophagus, this indicates the presence of esophageal atresia. Air within the GI tract at this age suggests existence of tracheoesophageal fistula, distal to the level of esophageal atresia. Definitive management requires surgical repair as well as additional screening or associated congenital malformation should occur. Okay, next.
Okay, next.
Wait. Let me read the other ones. Radiostalom and CT scan may be utilized to further assess the esophageal and tracheal anatomy of the newborn infant in the setting of equivocal findings after. Okay, next.
A previously healthy 37-year-old woman comes to the physician because of persistent headache for a week with history, persistent headache for a week with occasional episodes of nausea when the pain is most severe. She has had no other neurologic findings. Use of non-steroidal anti-inflammatory drugs have provided no relief. She has smoked one pack of cigarettes daily for 20 years. Her last pregnancy is 3 years ago, was uncomplicated. Her last menstrual period was 2 weeks ago. Her pulse is 72 per minute, respiration 14 per minute, blood pressure 170 by 20. Examination show no abnormalities but papilledema and right carotid bruit. Examination shows no abnormality except for mild papilledema and right carotid bruit. A renal duplex scan shows stenosis of the right renal artery, and a carotid duplex scan shows 25% stenosis of the right carotid. Which of the following is most likely cause of this patient's hypertension?
Ready?
Sorry, ready?
Yeah,
Yes. Is it
ready.
FND,
I
fibromuscular?
think I think so. Yes. Fibromuscular dysplasia is the of the renal artery is more common cause of renal artery stenosis in young middle-aged women. Fibromuscular dysplasia, non-inflammatory, non-atherosclerotic angiopathy of the medium-sized artery, renal and carotid that results um, in multifocal fibrous and muscular thickening of the arterial wall, which can lead to bead-like appearance and resulting stenosis. Renal artery stenosis is the cause of secondary hypertension because of abnormal stimulation of the juxtaglomerular apparatus from low afferent blood flow, leading to excessive production of RAS. The reduced apparent blood flow can result in progressive renal atrophy. Secondary hypertension should be considered a new onset or treatment-resistant hypertension in younger or otherwise healthy. There are two main causes of renal artery stenosis: fibromuscular dysplasia, atherosclerosis. In younger patients, if fibromuscular dysplasia is the most common cause, while older patients develop renal artery stenosis most commonly from atherosclerosis. Diagnosis is established with renal artery ultrasound or MR angiography, which are able to quantify the degree of stenosis and renal atrophy. Treatment involves angioplasty or stenting of the stenosis renal artery to improve flow. ACE inhibitors can also be considered for unilateral stenosis, but can lead to acute renal failure when it's bilateral renal stenosis. Okay.
Next. A 67-year-old woman with essential hypertension comes to the clinic. Essential hypertension comes to the physician because of 6 month history of moderate aching of her left arm when she carries grocery bags. When she carries grocery bags, she does and does anything with the arm raised above her head and lifts anything heavy. 1 week ago, when cleaning a large mirror, she felt dizzy and almost lost consciousness. She smoked one pack of cigarettes daily for 40 years. Her pulse is 72 regular. Blood pressure in the left upper extremity is 115 by 85, and upper extremity pulses are normal. Muscle strength and sensation testing in the upper extremity show normal. Which of the following is the additional component of the physical examination?
Ready?
Yes.
Okay, so is BP measurement of the right upper extremity. BP measurement of the right upper should be assessed to determine differential upper extremity BP in the setting of possible subclavian steal syndrome. Subclavian steal syndrome occurs secondary to stenosis of the subclavian artery, proximal to the origin of the vertebral artery. Movement and exertion of the affected upper extremity results in reversal of flow from the ipsilateral vertebral artery into the subclavian artery to supply the upper extremity. This results in vertebrovascular insufficiency, which can manifest as dizziness, vertigo, imbalance, lightheadedness, and hearing disturbance. Most patients demonstrate differential blood pressure between the affected and unaffected upper extremity with greater than 15 mmHg differential between the two. Physical exam may also demonstrate subclavian bruit and auscultation and reduction and delay in the ipsilateral radial pulse. SNAT-D neck auscultation is useful for evaluation carotid bruit, which may indicate underlying carotid atherosclerosis or to assess for radiation of a systolic ejection murmur, aortic stenosis. Okay.
Why hyperabduction? This one.
Oh, hyperabduction maneuver is used for the assessment of thoracic outlet syndrome. It is performed through palpation of the radial pulse during hyperabduction of the ipsilateral shoulder beyond 90 degrees. This assesses for disturbances in the radial pulse secondary to thoracic outlet syndrome from underlying anatomical abnormalities, cervical rib, like cervical rib.
Okay. Next.
Mhm.
A 47-year-old woman is brought to the emergency department 30 minutes after being found unresponsive by her husband on the bathroom floor. Yesterday, she called the physician after noticing a small scratch on her left labius major and received a prescription for levofloxacin and received a prescription for levofloxacin. Her husband reports that she has had a 24-hour history of progressive vulvar redness, hardness, and swelling that spread to her left upper thigh and the lower abdomen. She has type 1 diabetes mellitus. She is unresponsive to physical stimuli. She is unresponsive to painful stimuli only. Her temperature is 37.2, pulse 130 per minute, respiration 30 per minute, blood pressure 70 by 40. Examination show erythema of the lower abdomen. Uh, Examination show erythema of the lower abdomen to the level of the umbilicus from the left thigh to knee. There is no crepitus. Physical examination shows a purulent discharge from an open laceration on the left labia major and marked edema on the labia major. Examination emergency debridement is performed. During the procedure, there is liquefactive necrosis of the subcutaneous tissue, fascia, muscle. Which of the following is the most likely causal organism?
Jeez.
Uh,
No, no, that one. Ready?
1 second.
Okay.
Liquefactive necrosis. Okay.
Okay, so did not see that one coming. Strep pyogenes, one of the most common causative organism, is one of the most common causative organisms causing monomicrobial necrotizing fasciitis. Necrotizing fasciitis refers to infection spreading along the deep fascial plane, most commonly from mixed flora like anaerobes, although it can occur secondary to a single organism. It typically presents as acute onset of pain out of proportion to examination finding, redness and paresthesia that progresses to anesthesia at the site of prior trauma or surgery. Risk factors include the severity of inoculation and underlying chronic systemic illness, such as diabetes, liver failure, or kidney failure. As the bacterial infection spreads along the deep fascial planes, bulla with or without crepitus may develop. The extent of infection is often difficult to assess by exam only. Treatment requires broad spectrum antibiotic fluid resuscitation and debridement. Often multiple sequential debridements are required for definitive diagnosis. It's not Candida albicans, these morphic fungus that can result in systemic infections such as esophagitis, disseminated candida in immunocompromised patients, can also cause vulvovaginitis and diaper rash. It's not a common cause of necrotizing fasciitis. Clostridium perfringens can result in myonecrosis and hemolysis, typically following traumatic injury. This may present as gangrene and associated crepitus gas gangrene. Okay. Ostidial spores can also survive in undercooked food, and if ingested, can result in food poisoning. Pseudomonas in gram-negative RODA can result in numerous clinical symptoms, including UTI, stomatitis, otitis externa, folliculitis, pneumonia, and bacteremia. Okay.
So strep pyogenes is the organism for monomicrobial neck fascia.
Mhm.
A 25-year-old woman has 2-year history of episodic bloody diarrhea, sometimes productive of blood and mucus without stool, ranging up to 25 anal discharges daily. Examination shows no abnormality. X-ray shows examination of the sorry examination of the intestine show generalized changes in the colon, including decreased size and narrowing of the lumen and loss of haustral marking. Results in endoscopic biopsy show mucosal microabscess. Which of the following is the greatest risk for the following evidence?
Wait, which one are you reading?
Sorry,
I thought we are 29.
I was reading 29. Yes.
Oh,
Am I reading wrong?
oh, never mind. Okay. Wait, can you read it again? I wasn't paying attention.
Okay. A 25-year-old woman has 2 year history of episodic bloody diarrhea, sometimes productive of mucus without stool, ranging up to 25 anal discharge daily. Examination show no abnormality. X-ray of the intestine show generalized ranges in the colon, including decreased size, show mucosal microabscess. Which of the following is the greatest risk for this patient's subsequent condition?
Wait, I have no idea. Ready?
Yes.
A cancer of the colon. Patients with ulcerative colitis. Oh, she has ulcerative colitis. Ulcerative colitis are at increased risk for development of colon cancer. Ulcerative colitis is chronic inflammatory condition within the spectrum of IBD that inflammatory bowel disease that results in inflammation and ulceration of the colonic mucosa and submucosa. Typically begins within the rectum and advanced proximally. Symptoms include chronic abdominal pain, weight loss, body diarrhea, abdominal blood tenesmus. Imaging typically demonstrates loss of ostral markings, diagnosis of ulcerative colitis by colonoscopy and biopsy, which demonstrate characteristic crypt abscesses. Um, Potential complications of ulcerative colitis are fulminant colitis, toxic megacolon, perforation, as well as because of the chronic inflammation of the colon, patient has increased risk of colon cancer. Screening colonoscopy is indicated every 1 to 2 years, starting at 8 to 10 years old after diagnosis. Oh, wait, starting at 8 to 10 years after diagnosis. Treatment includes immunomodulators, steroids, although total colectomy is generally curative and will eliminate the patient risk of colon cancer.
Next.
Mm-hmm.
Okay. A previously healthy A previously healthy 47-year-old man comes to the emergency department 2 hours after the sudden onset constant severe epigastric pain. She says that the pain feels as if he had been kicked in the abdomen. He appears diaphoretic. His temperature is 37, pulse 120, respiration 24 per minute, blood pressure is 100 by 60. Abdominal examinations show exquisite tenderness and rod-like rigidity of the epigastrium in the right upper quadrant. Lab studies show 15 hemoglobin 15.2, leukocyte 11,000, amylase 140, lipase 50. Which of the following is the most likely diagnosis?
Hmm. No, no. Ready?
Yes.
So it's perforated duodenal ulcer, acute sharp abdominal pain, rigidity, rubant tenderness, and guardian potential signs of peritonitis, peritoneal signs. And raise suspicion of perforated viscus. The most common causes of a perforated viscus are complicated peptic ulcer disease, appendicitis, diverticulitis. Given the patient's location of epigastric and right upper quadrant pain, perforated duodenal ulcer is the most likely cause. Perforated ulcer typically the disease Pep- peptic ulcer disease describes the presence of ulcers in the stomach and duodenum, which classically presents with worsening abdominal pain related to consumption, gastric, or lack of consumption duodenal food. Peptic ulcer disease is strongly associated with infection with Bacterium H. pylori. Persistent inflammation related to peptic ulcer can result in complications, including fibrosis, stricture, hemorrhage, perforation. X-ray preferably obtained in an erect or left lateral decubitus may demonstrate evidence of pneumoperitoneum. Um, yeah, emergent surgical apparatus is required for repair of the underlying perforated duodenal ulcer and to lavage the peritoneum to reduce the risk of sepsis. It's not I. Ruptured esophagus may occur from forceful vomiting like Beharbour syndrome, trauma, invasive malignancy, inflammation. Translocation of gastric contents into the mediastinum. Hmm, okay. Into the mediastinum can cause rapid progressive infection and sepsis from mediastinitis. Okay, so esophagus is chest and duodenal ulcer is abdomen. Okay, next.
3 days after experimental laparotomy for a stab wound to the abdomen. 3 days after an experimental laparotomy for a stab wound of the abdomen, a 20 sorry a 14-year-old boy has jaundice. He recently immigrated to the USA from Caribbean island. During the operation, three small enterotomies caused by the knife were repaired. Multiple long tubular structures thought to be roundworms were felt within the lumen of the bulb. They were not removed. He required 2 units of red blood cell. He required 2 units of he requires 2 units of packed red cell intraoperatively. Examination shows sclera litteris, abdomen is mildly distended and non-tender. Lab study shows hemoglobin 13.5, leukocyte count 10,500, bilirubin 3.5, direct is 2.9, ALP is 210, AST 40, ALT 55. Which of the following is most likely mechanism of this patient's jaundice?
Ready?
1 second. Yes.
So is bad luck obstruction for migrating worms. Bad luck obstruction for migrating worms is a early cause of the patient jaundice with evidence of Ascaris lumbricoides within the bowel. Ascaris lumbricoides, also known as giant roundworm, is commonly transmitted to fecal or root via ova within feces. Um, okay. After ingestion, the intestinal larvae can infiltrate the wall of the small bowel and penetrate into blood vessels where they might migrate to the lungs. Once in the lungs, they are coughed up and swallowed again. Final development into adult worm occurs within the small bowel, where they continue to produce eggs. And complications is called bowel obstruction at the ileocecal valve and retrograde migration within the biliary tree. This can result in subsequent biliary obstruction, which leads to jaundice and direct hyperbilirubinemia. Treatment includes administration of antiemetics like albendazole and ivermectin. What is it called? Ascaris? Ascaris
Lumbricoids.
lumbricoides. The lumbering tree men. So this one, uh-huh. Most common worldwide. Okay, large round. Eggs are ingested, then larvae migrate to the lung, causing pneumonitis. Okay, it's this one, yeah. Okay. Causing pneumonitis. Pandex suda has a leaf on the chest. Okay. And then, but enter the GI tract where they mature, can obstruct the intestines and the bile. Lumbar man standing in front of the tunnel enters blocked by rocks. Okay. Blocks the intestine of the biliary tract. Can cause pneumonitis. Okay.
Next.
Mhm. Next.
A 36-year-old man
Oh,
comes. Sorry.
sorry. Yeah. Next.
Yes. A 36-year-old man comes to the physician because 4-day history of bloody diarrhea. He has 16-year history of ulcerative colitis, treated with corticosteroid therapy. His temperature is 37.5, pulse 110 per minute, respiration 16 per minute, blood pressure 124 by 78. Abdomen is soft and distended. There is mild diffuse mild diffuse tenderness to palpation but no rigidity or guarding. Colon contrast studies show a constricting apple core non-obstructing sigmoid mass. Which of the following is the most appropriate next step in the management?
Ready?
Yes. Is it surgery, isn't it?
No, which one?
Proctocolectomy.
Okay. Yes. Proctocolectomy, most appropriate next step in management of for a patient with history of UC complicated by the development of colorectal cancer. UC is a chronic inflammatory condition within the spectrum of IBD that results in inflammation and ulceration of the colonic mucosa and submucosa, typically beginning with the rectum and advancing process. Symptoms include common abdominal pain, weight loss, body diarrhea, abdominal bloating, tenesmus. Imaging typically demonstrate loss of Ostrom markings. Diagnosis of UC is by colonoscopy biopsy, which demonstrate cryptasis. Because of chronic inflammation of the colon, patients are at subsequently increased risk of colon cancer. Screening colonoscopy every 1 to 2 years, starting 10 to 10 years after diagnosis. Colorectal cancer of the descending and sigmoid colon is often infiltrative and partially obstructive, producing apple core lesions. In contrast, on contrast, barium enema. Following appropriate staging diagnostic studies, definitive management should be entailed proctocolectomy, which will serve to appropriately remove the current cancer, curtail future risks for cancer, and provide curative management. It is not the segmental colectomy may allow for the adequate removal of patient's colorectal cancer, but it will leave the remainder of the colon in place, which will not improve the patient's ulcerative colitis symptoms and reduce the risk for future colorectal carcinoma. What's the proctocolectomy just mean remove what the entire.
Proctocolectomy. You see in the procto means anus, isn't it?
Oh, anus, okay.
Intercolon along with the rectum.
Okay, colon and rectum and segmental commutations of colon. Okay.
So, in short, proctocolectomy is like anal plus ulcer. Sorry, plus. Okay, let's move on next question. I don't know what I am talking
Okay.
about. A 20-year old man is brought to the emergency department 30 minutes after being involved in motor vehicle collision. Unrestrained front seat passenger during he was unrestrained front seat passenger during the head-on collision. The left lower extremity is flexed at the hip, shortened, adducted, and internally rotated. He is unable to dorsiflex the knee. Which of the following is the most likely diagnosis? Ready?
Now give me a second.
It is
Mm,
either neck dislocation or hip dislocation, neck fracture or hip dislocation, isn't it?
Why you um, leftover extremity is flex at the hip, short and adductive, so like this. And he's unable to dorsiflex the ankle. Dorsiflex, making it up. So it will be
Involvement of the peroneal nerve also.
between femoral nerve contusion and hip dislocation.
Yes, these two is the differential.
I'll go with femoral nerve because they say something about the ankle. Okay, ready?
So what have you picked?
The the nerve, because I think they say something about the ankle, so must be
No.
like a nerve. I'm thinking
Okay, let's see.
it's hip dislocation. Never mind. Hip dislocation is commonly associated with a posteriorly directed force during a car accident, where the femoral head is forcefully displaced posterior out of the acetabulum. Posterior hip dislocation are more common than anterior dislocation. And on physical exam, they typically present as short ADD, and internally rotated lower extremity is flexed at the hip. There is a risk for injury of the sciatic nerve, sciatic nerve, and avascular necrosis of the femoral head if there is compromise of the proximal femoral vasculature. Diagnosis is based on the presenting traumatic history, physical exam finding, and X-ray and CT scan. Treatment requires close reduction followed by abduction bracing of the hip. Reduction should not be delayed for imaging. A shorter time to reduction is associated with fewer complications and improved outcome. And it's not what was that? Femoral nerve contusion will result in dysfunction of the femoral nerve, which innervates the anterior compartment of the thigh, quadricep, and provides sensation for the anterior thigh and anteromedial leg via the saphenous nerve. An inoffemoral neck fracture commonly presents as a shortened and externally rotated lower extremity, not internally rotated, as hip dislocation. Okay.
So neck is externally rotated and his
Mm-hmm.
hip dislocation is internally rotated.
Mm-hmm.
Okay. A
Yeah.
52-year-old man comes to the physician 3 months after an episode of dysphagia while eating meat. He has had heartburn for 2 years. It has been unrelieved by antacids for 9 months. He has smoked two packs of cigarette daily for 35 years. Examination shows no abnormality. Hematocrit is 32. Free blood smear shows microcytic hypochromic erythrocyte. Upper GI endoscopy show erythema abdominoculata between a hiatus hernia and mid esophagus, while multiple linear erosion. Which of the following is the most appropriate pharmacotherapy? Ready?
Yes, second. Linear erosions. Wait, linear erosions. Isn't that CMV? If it's CMV, none even makes sense. Okay, ready.
Okay.
Is omeprazole. Omeprazole PPI is the first time pharmacotherapy for patients presenting with GERD and associated reflux esophagitis. GERD typically presents as burning epigastric and lower chest pain, often in association with consumption of large meal or trigger food, often worse with supine positioning. Acid reflux in the esophagus causes mucosal irritation and inflammation, which can present as mucosal redness and multiple erosion, reflux esophagitis. Okay. Over time, if the GERD remains untreated, metaplasia can occur, leading to Barrett esophagus, a state of premalignancy marked by intestinal metaplasia uh, of the distal esophagus. Untreated, this can subsequently lead to esophageal cancer. Omeprazole irreversibly inhibits the hydrogen potassium ATPase in gastric parietal cells, reducing the stomach acid production, allowing for the neutralization of allows for neutralization of stomach contents, limiting the inflammatory and erosive sequelae of GERD. in the distal esophagus and allowing for appropriate healing of the previous esophagitis. It's not sucralfate provides physical protection to the gastric mucosa and gastric ulcers, allowing for establishment of pH mucosal gradient and resulting in providing ulcer healing. It is not as effective as PPI for GERD. Okay, next.
A 55-year-old man is admitted to the hospital because of progressively severe anginal pain secondary to coronary insufficiency. Coronary bypass is scheduled, and the advantage and the disadvantage of the procedure are relevant details are carefully explained. The patient indicates that he undergoes he has been told, including the risk and signs of the hospital's consent form. In the occupation from holding area developing too frightened and to allow the operation and demands that it can be cancelled. Which of the following is the most appropriate course of condition?
Hmm.
Have I read all the question?
Yeah, you have read all the question. Mm. Ready? That's a tricky question. Ready? Sorry.
Mm, okay.
Between A and B, cancel the operation. Oh, even if he is agitated. Okay. Patient with patient autonomy is one of four common medical ethical principles, along with beneficent and maleficent justice. Autonomy posits that patients have the right to make decisions provided that they have the decision-making capacity to do so, and that they have been provided with appropriate information for use in making such a decision. Consenting adult with the decision-making capacity has the right to refuse some or all aspects of medical care, even if such decision may result in mortality. While the patient initially consented to the operation, he then expressed concern after an adverse reaction and demanded the procedure to be cancelled. Provided that the physician determines the patient has appropriate capacity, the patient may elect to refuse the procedure at any time, even after signing the consent form. Therefore, it's not appropriate to cancel the operation. But he was confused and agitated. Okay. Proceed with the operation based on the patient informed consent are not appropriate as they do not respect the patient's autonomy. As long as the patient is deemed to have decision making capacity, the patient has the right to refuse intervention. Okay.
Okay. Let's take a break for 5-10 minutes. You have done
Okay.
your breakfast?
No, I can. I'm gonna go do it now.
Okay.
I was there just eating and watching TV. I completely forgot. Like, man, I have to go back.
Okay,
Oh
let's
my
do
God,
some
this is so bad.
questions.
This is so bad. Okay, ready.
Yes. A 42-year-old woman gravida 3. A 42-year-old woman gravida 3 para 3 is brought to the emergency department because of severe abdominal pain that awake him from sleep 8 hours ago. She has she had one similar episode 3 months ago that resolves without treatment. His temperature is 37 degrees Celsius. Abdominal examination shows right upper quadrant guarding and normal bowel sounds. Hemoglobin concentrations are 12 gram per deciliter. Leukocyte count is 12,000. Total serum bilirubin concentration is 1.1. X-ray of the abdomen shows no abnormality. Which of the following is the most appropriate next step in the management?
Where's my pen? Already?
Yes,
So is abdominal ultrasound. First-line diagnostic exam for evaluation of potential cholecystitis. Acute cholecystitis secondary to obstruction of cystic duct from gallstone, which results in subsequent inflammation of the gallbladder wall. Typically presents as fever, right upper quadrant pain, tenderness, and to palpation often impeaches with history of gallstone. Is occasionally preceded by symptoms of biliary colic from cholelithiasis. Characteristic ultrasonography findings of acute cholecystitis include gallbladder wall thickening, hyperemia, pericholecystic fluid, presence of gallstones, and sonographic Murphy sign. If ultrasound findings are equivocal, hide scan can be performed. This is nuclear medicine scan that evaluates for patency of the cystic duct and biliary. Treatment includes supportive therapy, IV fluids, IV antibiotic, and urgent cholecystectomy. Okay,
Mm,
next.
yes. An asymptomatic 72-year-old woman comes to the physician for a routine health maintenance examination. Her pulse is 76 per minute, respiration is 18 per minute, blood pressure is 134 by 90 millimeter of mercury. Examination shows no abnormality. Her hematocrit is 35%. Erythrocyte indices show microcytic anemia. Test of the stool for occult blood is positive. Which of the following is the most likely cause of this patient's anemia?
Hmm.
Is it small bowel or cecal malignancy?
I think it's malignancy. Yeah.
Is there anything you want,
I was
like
going with
why microcytic anemia? Older woman microcytic anemia.
yeah, but it doesn't say she lost any weight already. I guess yeah,
You
maybe
are thinking about peptic ulcer disease.
no. I'm between small bowel malignancy, Meckel, and hemorrhoids. But Meckel will be in
Mickels would be in the small, like in the younger age.
yeah, and hemorrhoids, the internal hemorrhoids, they are not painful. So why cannot be that?
Yes,
And then but I guess small bowel malignancy. I guess let's go with small bowel. It makes more sense. Okay, ready?
yes.
Where am I? Never mind. It's cecal malignancy.
I
Refers
was
to
in between A and E.
mm-hmm.
I
Cecal
know.
malignancy refers to colon cancer of the cecum, which is often insidious that can present with chronic blood loss resulting in iron deficit. That's a new one. And stool that tests positive for occult blood. Test for occult blood is sensitive but not specific for malignant vascular infectious and inflammatory GI conditions, included but not limited to colorectal cancer, AV malformation, polyposis, diverticulosis, IBD, gastritis, ulcer, peptic ulcer. In the setting of unexplained microcytic anemia in a person over 50, males or postmenopausal females, colon cancer should be considered. If a lower GI tract source of bleeding, such as colon cancer, is suspected, colonoscopy is indicated. It is not hemorrhoid because hemorrhoids result from dilated submucosal veins in the anal canal. They are commonly classified as either internal or external in relation to the pectinate line. Internal hemorrhoid typically painless owing to the while external are painful. While hemorrhoid can result in brighter blood per rectum, bleeding is generally mild and unlikely to cause okay, it's mild. Meckel diverticulum is one of the most common causes of painless bloody stool in children. Meckel diverticulum results from okay. Typically presents in childhood, most commonly by age 2 years old. It's not small bowel malignancy rare. The most common malignant small bowel tumors are carcinoid, lymphoma, leiomyosarcoma, and adenocarcinoma. Colorectal cancer is significant more common tumor of the GI tract to explain the patient's microcytic anemia should be investigated for. So small bowel is red, colorectal cancer is more. Okay, next.
Okay. And 8 months after undergoing an abdominoperineal resection of the rectum for adenocarcinoma, a 62-year-old man has a pelvic tumor and hepatic metastasis. He has a poor appetite. He is given sustained release morphine orally to control pain. 2 weeks after, he has a fecal infection in the colostomy area. To prevent recurrence of this condition, which of the following is the most appropriate next step in the management? Should we stop?
Don't think so because he has cancer. So why would you stop it? I'm between A and B. I know we have to maintain because he has cancer, so morphine is helping to control the pain. But should we just increase the fluid or just start the stool softener?
Increased fluid will cause uh, increased fluid will help to bowel to move.
Mm, Guess.
Okay.
Ready?
Yes.
Okay, so you have to add stool softeners. Maintain the dose of morphine and initiate a daily regimen of I don't know cathartics mean what. And stool softener is the most appropriate next step in management for adequate treatment of the patient cancer-related pain and opioid-induced constipation. The patient has a history of metastatic renal rectal cancer. To provide the patient with sufficient comfort for his metastatic cancer-related pain, opioid medication are an appropriate first-line analgesic medication. While the overall use of opioid medication in the general public should be limited, and alternative therapy instituted in management of chronic pain because of the risk addition, opioids are most effective at providing relief in cancer pain. Common adverse effect of opioid is constipation because of opioid bowel hypomotility and increased anal sphincter tone, impaired the defecation reflex. Oral cathartics like magnesium citrate and stool softener that doctor said should be studied to elevate patient identification. It's not the increased fluid intake would not appropriately treat the patient opioid constipation, as the constipation is secondary to decreased bowel motility and increased anal sphincter. Increased fluid intake will not adequately counteract the patient's constipation, as physiologically nearly all fluid will still be absorbed by the colon prior to defecation.
Mhm.
Okay, next.
Yes. A previously healthy 27-year-old woman is brought to the emergency department because of 3-hour history of increasingly severe lower abdominal pain. The pain involves the left side. The pain involves the left side and radiates to the back. Her temperature is 100.4 degrees Fahrenheit. Examination shows 8 centimeter exquisitely tender ovarian mass. A pregnancy test is negative. Her leukocyte count is 10,400. Ultrasonography confirms the mass. Which of the following is the most appropriate next step in the management?
She has torsion,
Maybe.
or is it an infection? Nah, infection, it says a mass.
Yes, she has tender ovarian mass.
Oh, this is torsion. Ready?
Yes.
So it's laparoscopy indicated for the evaluation of acute lower abdominal or pelvic pain associated with REMAS. The differential diagnosis for tender adnexal mass resulting in acute pain includes ectopic pregnancy, ovarian torsion, tubovarian abscess, appendicitis, rupture ovarian cyst. Even though the mass is located within the ovary is exquisitely tender and the pregnancy is negative, potential for ovarian torsion is super high. Ovarian torsion occurs secondary to hypermobility ovary or the presence of large adnexal mass. Patients typically present with acute or abdominal pain and pelvic pain, which may be lateralized to the side of torsion, along with nausea and vomiting. Evaluation of ovarian torsion includes visualization of in ultrasound. Treatment includes supportive therapy, pain management, definitive intervention laparoscopy to evaluate the adnexal, attempt the torsion of the ovary, and if necessary, remove the ovary. It's not, where was I? BC. Safety as long as the cycling will be appropriate for treatment of STI or outpatient management of PID. Ibuprofen is said it can be used for treatment of primary dysmenorrhea, this patient requires surgical intervention for possible ovarian torsion. Okay.
Okay. Next. A previously healthy 42-year-old woman is admitted to the hospital for treatment of acute biliary pancreatitis. On hospital day 5, she is passing flatus, but she has not had a bowel movement for 3 days. She has lost appetite but does not have nausea. Her current medications are patient control, morphine, pump, and IV metronidazole. Her temperature is 38, pulse is 80, respiration 20, blood pressure 130 by 75. Abdominal examination shows mild tenderness in the right epigastrium and uh, central abdomen to direct palpation. There is no rebound. A central venous catheter is inserted. Parenteral nutrition is begun. Due on hospital day 6, sodium 135, potassium 4, chloride 102, magnesium 1.6, calcium 8.6, phosphorus 2, bicarbonate 26. Which of the following is most likely is explanation? Which of the following is the most likely explanation for this lab finding? Lab finding.
Mhm. I, I don't know what is happening.
Yes, I
What is happening with them? Because the labs are normal. Like,
magnesium is low.
no, magnesium is, I mean, normal. It says 1.5 to 2. He has 1.6. I mean, the
When
sodium
is the
is,
problem in the lab? I
I
don't
don't know.
understand.
Phosphorus is 3 to 4.5. Okay, phosphorus is the only thing that's a bit low, I guess. But I, what is the issue? The, like, like refeeding syndrome, everything
Defeating
will be,
syndrome will, what can I say? There will be muscle breakdown, potassium will be high, there will be tons of insulin, there may be hypoglycemia.
yeah, then it's not that. I guess our dynamic is the only thing that, I don't know what is the issue on the here. That's the thing.
Let's choose an
Okay,
atypical one.
okay. So the answer is refeeding syndrome. Jesus Christ. So refeeding syndrome is, I don't even understand what was the issue here. Refeeding is potentially fatal disturbance of fluid and electrolyte balance that occurs in malnourished patients after receiving either enteral or TPN refeeding. The underlying risk factor for refeeding syndrome is prolonged fasting, which results in hormonal and metabolic changes that result in decreased carb metabolism, with increased usage of fat, ketones, and fatty acid, and protein as the main source, whatever. After initiation of refeeding, the subsequent increase relative glucose concentration in the blood relative to previous starvation state results in increased insulin production. This relative hyperinsulinemic state stimulates the cellular uptake of potassium and increased production of fat, protein, and glycogen, which require minerals such as phosphate and magnesium, and the coenzyme thiamine. Severe depletion of each can ensue. So there will be low magnesium, low potassium, low phosphate, and low thiamine. Lab values typically demonstrate hypophosphatemia, hypomagnesemia, hypokalemia, depending on the severity. But here everything is fine. Anyway,
Yes,
patient present, I don't understand. Patient presents with, I guess potassium, phosphorus was the only thing that
phosphorus, hypophosphatemia.
a little bit low, I guess. Patients present with symptoms related to the resultant electrolyte and vitamin deficiency, along with retention of fluid resulting in significant edema. But he doesn't have any symptoms. Wait, doesn't have no symptoms. Okay. It's not a dynamic idiom referred to intestinal hypermotility without mechanical obstruction, most likely occurring following surgery in the setting of electrolyte abnormalities like hypokalemia, and typically present with a diffuse small and large bowel dilation. Okay, here I guess the bowel is normal. Okay, I guess we will take it like that.
So,
Next.
what is the
Mhm.
take home from this question?
I think the key was just that they started,
Hypophosphatemia.
yeah, and they started. He went through a surgery, and then they started TPN. There's the TPN right here. I guess that was the key. He went through surgery, and then they started TPN. So yeah, so he was fasting. Oh, he was 5 days in the hospital, so he was fasting for 5 days basically, and then they started TPN.
Okay.
Next, that was a weird one.
Should we stop? Because
Oh,
we have 10 questions.
up to
I,
you. Yeah,
I I am very sleepy. Trust me.
me, me too.